Hi, in this video, we're going to talk about the brain and alterations in our cognitive systems, problems with motor function, all of the symptoms that we have with disorders that are related to the central nervous system. So, cognitive changes, LOC changes, differences in the brain function, symptoms that we see with disorders of the brain and the spinal cord. So, first off, just a little list of the levels of consciousness. Okay. So, these are obviously the very first one would be awake um, and alert. Okay. So, when we have awake and alert, that's kind of your baseline, right? Your normal level of consciousness for somebody who doesn't have any kind of brain disorders or anything like that. Now, clouding of consciousness is a very mild form of altered mental status where you have some inattention and some reduced wakefulness. So we kind of think of it as like a being in a fog. Okay, so like a mental fog. You're just slightly less awake or aware than normal. You're not as aware of time or your surroundings. You find it difficult to pay attention. So that's when your mind is foggy. Okay, so that's clouding. Now, a confusional state, usually known as an acute confusional state, this is more profound than just a clouding of your consciousness. And this is going to include disorientation, difficulty following commands. Drugs and alcohol can cause this, can cause an acute confusional state. Lethargy is severe drowsiness. Okay, so we have drowsiness, obviously, we have. But then lethargy is going to be a more severe drowsiness where you can be aroused, but it takes a decent amount of stimuli to arouse you rather than, just being slightly drowsy, which, a little bit of stimuli might arouse you. And then they'll drift back to sleep. Okay, that's what lethargy is. Now, if you're obtunded, that's a state similar to lethargy, where you have you tend to sleep more than normal. Okay, you have slowed responses to stimulation. It's a little bit deeper than lethargy. Okay, so you have less of an interest in an environment. So we're kind of going down the line here. A stupor means that only vigorous and repeated stimuli will arouse the individual. When left undisturbed, they will immediately lapse back into the unresponsive state. And then finally, there's a coma when they are completely unarousable. Okay. Now, we judge comas in levels of consciousness with the Glasgow Coma Scale. And this is a pretty standard scale. Your best response is a 15. And so if you are awake and alert and talking to people, you're going to be a 15. Worst possible response is actually not a 0, it's a 3. So the scale goes from 3 to a 15. And it's basically just, are you responsive? Are you interacting with people? Do you have motor responses? Do you have verbal responses? And then are your eyes opening? What kind of stimulus makes you open your eyes? So what happens when we have an altered LOC then? So obviously level of consciousness changes that we just talked about, okay? But what are those related to? Well, we can have those LOC changes due to a structural problem. So say a brain injury, a brain tumor, a stroke. And depending on where that structural problem is and how large it is, how severe it is, then that's going to tell us how severe our LOC changes are going to be. Okay, so we very frequently use the Glasgow Coma Scale when we have someone with a TBI, a traumatic brain injury, or a stroke, so that we can judge how bad it is. Okay. Now, you can also have changes in LOC due to metabolic disturbances, okay? So metabolic disturbances are things like hypoxia, electrolyte imbalances, so like your sodium's out of whack. Hypoglycemia can cause altered LOC. Those are all metabolic, okay? And then we also have psychogenic changes. So psychogenic changes in LOC may signal some kind of psychiatric disorders, okay? And sometimes those psychogenic changes in those, the person may appear unconscious, but is actually physiologically awake. Okay. And so, but it's a symptom of a psychiatric disorder. So some of the other manifestations that we'll look at here include pattern of breathing, changes in the pupils, changes in the eye muscles, so the oculomotor movement, motor responses, and then things like vomiting, yawning, hiccups. Vomiting can be vomiting is a sign of increased intracranial pressure. Yawning is a sign of hypoxia sometimes, because you need more oxygen. And hiccups, so it's interesting. Hiccups can be stimulated obviously by problems with like the diaphragm or whatever. And you never really know what causes some hiccups, but there are some hiccups that we call them central hiccups, that occur because you've got lesions in the central nervous system, somewhere in the location of the phrenic nerve. PHRENIC. So sometimes hiccups are a sign of a stroke, brain tumors, MS. We can see those because of of an impact on the phrenic nerve. All right, so first off, let's look at pattern of breathing. So Cheyne-Stokes respiration is an abnormal pattern of breathing. First one on the picture there. And what happens there is you get progressively deeper and sometimes faster breathing, followed by a gradual decrease that results in a temporary stop, apnea, okay? And then the pattern repeats. And so every cycle takes, just like a minute, maybe 2 minutes. So we will see that sometimes with a stroke, traumatic brain injury. Sometimes we just see it related to heart failure even. So lots of things that can indicate, but it means that something's going on that we need to investigate further. Central neurogenic hyperventilation is characterized by deep, fast breaths that are occurring at least 25 a minute, and that respiratory rate will get more irregular. This is typically a sign that the patient's going to go into a coma, okay, when we have a central neurogenic hyperventilation. Apneusis respiration is characterized by these deep gasping inspirations with a pause when they inhale, and then they release, but they don't let it all out, okay? So they have a gasp for air, but they don't release right away, okay? This is usually damage to the midbrain and the pons, so we're talking about some pretty severe brain damage there. Cluster breathing, it's also called Biot's breathing, BIOT, but this is characterized by clusters like you see there. So they get pretty fast respirations in a little cluster, and then they have apnea. And then they have some fast breathing again, and then they have apnea again. And then finally, ataxic breathing, that is completely irregular, okay? So you've got pauses, you've got fast breathing, you got more pauses. There's no pattern to it. And then eventually it gets to be what we call agonal, which is barely breathing, okay? Agonal respirations are what we see if somebody's dying. Here we see it, we see ataxic breathing with severe brain damage, stroke, trauma, herniation of the brain. And then we can also see that with opiates, with severe like opiate overdoses. All right, we also see pupillary changes. So when we have pupil changes, for anytime you have somebody with neuro symptoms, we always look at the pupils, right? And so certain pupillary changes mean certain things. If only one pupil is reactive and the other one doesn't react, then that means a unilateral lesion in the brain. If both of them are the same, then we're talking about something that is global, or perhaps something that is not related to a lesion per se, but maybe a drug, for example. So metabolic imbalance there at the top there. You can see small pinpoint pupils with opiates, okay, with opiate and intoxication and ODs. Fixed and dilated pupils that aren't moving at all mean brain death. So the way pupils move can really tell you if something's going on with the brain, and whether it's on both sides. Now, I do caution you that if you have a patient who has cataracts or who has had eye surgery, those particular their pupils will not react normally. And so don't forget to pay attention to your other clues, okay? Don't simply rely on the pupils. Oculomotor responses here. So there's a couple different things shown here. At the top is what we call doll's eyes. If your brainstem is intact, then when we turn the patient's head, the eyes will move away from the direction of turning so that they're still looking at the nurse, okay, rather than fixed straight ahead. So if you remember the dolls that had the weights in the eyes, when you turned them, their eyes looked forward, okay? So this is a good thing to have doll's eyes. And it is to not have doll's eyes where the eyes move with the head and stare straight ahead and don't change. That is a sign. So that would be a negative doll's eyes. And that's a sign that your brainstem is not intact. Now, the caloric reflex is a test that involves irrigating with cold water in the ear. So when you put cold water into the ear canal, then the eyes should look at the ear that is being irrigated. If the patient's eye does not move, it does not react, then we've got an issue with brain damage. Okay, we have cerebral damage here. Okay, so in a comatose patient, if their eyes don't move, if they have an absent reaction, then we know that we've got a very high level of cerebral damage. Moving on to motor responses here. At the top, we have what's known as posturing, which we'll talk about in a little bit. And then down at the bottom here, we have different reflexes here. So the grasp reflex, this is typical. This is common. This is a reflex that is present at birth, but it disappears as a baby grows up. And it will have completely disappeared by a few months of age. If it reappears, then it is a sign that we have severe brain damage. So that's the grasp reflex. B is actually called the snout reflex, and that is if you touch right above the lip, then the lips turn toward the finger. That's called the snout reflex. Again, this is normal as a very new baby, but not later, okay? The palmamental reflex, again, normal in babies, but not later, is if you scratch that thumb, not only will the thumb twitch, but your chin will twitch as well. And then finally, the suck reflex. The suck reflex is if you put something at the lips, the baby will suck on it, okay? And it's an involuntary suck, okay? The snout reflex is also called the latch. It's also called the rooting reflex, okay? So these are all motor responses, reflexes that we check for to determine if somebody has some severe brain damage. All right, so one of the ways we can have severe brain damage is an increase in intracranial pressure. So how do we get increased ICP? Well, we either have an increase in the content in the brain, so say a tumor, okay? Maybe we have cerebral edema. Maybe we have too much CSF. Maybe something's bleeding, and so now we have excess blood in the brain. Anytime you have an increase in the amount of content in the brain, you gotta take that much off, okay? And so it displaces your CSF, and it alters cerebral blood flow. So typically, if somebody has increased ICP, we are not going to be able to tell at first, okay? So note on this chart here, we've got the way that all of the stages of increased ICP. And if you'll look at this, at stage 1, the patient's awake and alert, pupils are fine, breathing's fine, blood pressure's fine, heart rate's fine, okay? Stage 2 here, the first indication that we might have some increased ICP would be restlessness or some changes in LOC, okay? Maybe your patient's getting a little sleepy. Maybe they're starting to get confused. Everything else is normal, okay? Now, after that, though, now we really have a problem, right? So we need to stop it while it's here. In stage 3, at this point, they are very difficult to arouse and eventually goes through into a deeper and deeper coma. At this point, maybe our pupils are starting to change here. Okay, maybe our breathing is starting to change. We also have a widening pulse pressure, meaning that the systolic goes up and the diastolic goes down. Because remember, your pulse pressure is the difference between the two. And as the pulse pressure increases, then we may see changes in the heart, in the actual pulse rate itself. Okay. This is not going to be as diagnostic though as these right up here. Okay. The mental status, the pupils, and then the breathing. So what is cerebral edema, since I talked about that being an increase in intracranial pressure? So this is an increase in the fluid in the brain. Now that fluid can be in the cells or it can be in the interstitial spaces or extracellular. There's a few types: vasogenic, cytotoxic, and interstitial. Vasogenic means that the fluid is leaking from the capillaries, okay? So this is going to be, this is actually very similar to regular edema. So when you have edema in your feet, for example, it's because the fluid, you've got leaky capillaries and the fluid is coming out of the capillaries. Cytotoxic cerebral edema is caused by dead blood cell or dead brain cells, okay? So we have cerebral ischemia, and as a result of that, when the cells burst or when the cells die, okay, then all the fluid within them gets out into the interstitial space, okay? So cytotoxic, meaning that something has killed the cells, okay? Interstitial cerebral edema is when the CSF it flows out of the ventricles into the interstitial areas of the brain. So this would be patients with hydrocephalus or meningitis, okay? And we're going to talk about both of those coming up. So here is so Cushing's triad is three symptoms. The triad is three symptoms that are characteristic of increased ICP. And your symptoms here are an elevated systolic blood pressure, a decreased pulse, and decreased respirations. Now, this is to be contrasted with shock, which is where you have a decreased pulse, a decreased blood pressure, an increased pulse, and increased respirations, okay? So when we have increased ICP, these are the things that we're going to see, and they're opposite of shock. So other than vitals, though, like I showed you with the graph here, with the different stages here, the things that you're going to assess for, obviously, those changes in LOC, because remember, those are the first things to change, okay? Maybe your patient isn't responding as well. Maybe they're getting confused, okay? We're going to look at their eyes, look and see if their eyes are moving correctly, if their pupils are reacting correctly. Do they have any sort of posturing going on? We're going to talk about posturing, okay? Decerebrate, decorticate, flaccid posturing. Flaccid posturing is very common after strokes. Are they responding to motor commands? Are they responding to the commands, but also are they able to do things like squeeze your fingers, okay? A headache is one of the number one signs of increased ICP. Your patient may have seizures. We talked about Cushing's triad out already. The vomiting that is associated with ICP is not the same kind of vomiting that you get when you're sick to your stomach and you've felt nauseous for hours and finally you throw up. This is not the same. This is not vomiting that is caused by nausea. This is very fast vomiting. It occurs out of nowhere, and it may be projectile vomiting. Always have your patient talk to you. Changes in speech, whether it's slurring of the speech or a difficulty finding the correct words. All of those are going to be indicative of changes in ICP. In a baby, we can't do this, right? We can't do these things. So what we're looking at in babies are the fontanelles bulging? Okay, are the cranial sutures separating more than usual? Is their head circumference increased? Could be a sign of hydrocephalus, okay? Also a very high-pitched cry that is not normal for them, okay, unless they were born with hydrocephalus. So speaking of hydrocephalus then, this is where we have excess fluid in the ventricles, okay? Or the subarachnoid space, or both. Typically, we're talking about the ventricles. So here in this picture, you can see the difference. You can see all of this CSF that's in the ventricles, and that is pushing on the brain, okay? So it can be either that they're making too much CSF, or it's not reabsorbing the way it should, okay? Or it's obstructed within the system itself. So all of those things can cause hydrocephalus. So there's several different types of hydrocephalus. Non-communicating hydrocephalus is when the CSF flow is obstructed within the ventricular system, or it leaving or the way it leaves to the arachnoid space. Okay, so you've got a blockage from the CSF that is in the ventricles to leave it, okay, to get into your subarachnoid space. This is also called obstructive hydrocephalus because it can't, and this is an acute hydrocephalus, okay? It's also called intraventricular hydrocephalus. Communicating hydrocephalus means that the flow of CSF is blocked after it leaves the ventricles. So communicating means it can still flow between the ventricles. Those are open. Okay, that's usually a chronic condition. Normal pressure hydrocephalus is an abnormal buildup of CSF in the brain, in the ventricles or the cavities, and it occurs if the flow is blocked some way. Okay, it's a type of communicating hydrocephalus. It's most common in the elderly because we see it a lot with subarachnoid hemorrhages, which can be caused by head trauma. It can happen because of an infection, a tumor. It can happen after surgery. There are some people who get it for no reason at all, and we call that idiopathic normal pressure hydrocephalus. All right, so brain death. Brain death is when the body can no longer maintain internal homeostasis. So the body can no longer self-regulate. Brain death criteria are actually set by state law. And so this is kind of interesting. But a lot of times the state law will determine what tests have to be done for brain death, who can declare brain death, what criteria are there. And so basically when we have somebody who is brain dead, we are talking about somebody who has no motor response, no reflexes, no spontaneous respirations, okay? We will do scans, we will do EEGs, and there's nothing there. It'll be a flat EEG, what they call electrocerebral silence. This has to persist for a certain period of time, Okay. They also check brain flow, looking for the flow of fluids in there. And so if there isn't any, that's another criteria. Now, typically, there are certain things that have to be done first, and that is that first of all, the patient has to be warmed to a normal temperature. And so there's a saying that says you're only dead when you're warm and dead. And that's because with hypothermia, as we talked about in a previous video, with hypothermia, the brain function is severely depressed. But that's okay because we're protecting the brain with hypothermia. So you have to warm the patient up before we do that. Okay. When we do brain death criteria, typically we are talking about 2 independent practitioners. It can't be declared by one person. This isn't something you want to make a mistake on. Okay. We also have to do the tests several hours apart, usually once one day and then repeat it the next day and have complete lack of everything on both days. Okay. That's brain death. Now, cerebral death is an irreversible coma. This is just death of the cerebral hemispheres. The brain stem and the cerebellum are still present, they're alive, they're functioning. Your body can maintain homeostasis, but you do not have any behavioral or environmental responses, meaning that you don't respond to stimulation at all. You don't respond to people talking, environmental, so sounds, lights, things like that, okay? So people who are in or have cerebral death, they were either in a coma to start with and they stay in a coma, or maybe they were, if it was somebody who had, say, cardiac arrested and we got them back, we call that, and their brain just was deprived of oxygen for too long. It's called an anoxic brain injury. They will emerge into what we call a persistent vegetative state, which again it's a coma. Okay. So people who've had anoxic brain injuries are the people who are in these persistent vegetative states. Now, they may also go into what we call a minimally conscious state. A minimally conscious state is where your patient is responding to some things. Okay, it's not. They do have partial conscious awareness. It's not a persistent vegetative state. It's not that bad. Okay. They do have definite responses. They have definite reactions to the environment. They have definite reactions to people, things like that. Okay. And it's not just a reflex. They may be able to follow simple commands. They may be even able to say yes or no, although it's not always an accurate answer. Okay. They may have, they may be able to state their name. They may reach for things. Okay. So that would be a minimally conscious state. And one of the things with the minimally conscious state is that a lot of people do improve with that. And so that's really good when we see improvement from there. Locked-in syndrome is different. So in locked-in syndrome, they cannot communicate, but they have their awareness is there. Okay. And so with locked-in syndrome, it's complete paralysis of all of the voluntary muscles, except usually their eyes. They can think, they're conscious, but they can't speak, they can't move. And so the only way they can communicate is through their eyes, is through blinking. So it's very, very rare. And it's very rare that somebody will come out of it as well. All right, so different alterations in awareness are next. So, first off, when we're talking about selective attention, so this is your ability to select from available competing stimuli. So, as you watch this video, you're listening to me, but there could be sounds in your periphery that you are tuning out. Okay, a selective, you are supposed to have selective attention. You're not supposed to hear the dog barking in the background, your roommate cooking lunch, or something like that. Okay. A selective attention deficit means that you can't ignore that irrelevant information. Okay. You can't concentrate. And there are different things that will cause you to have a temporary selective attention deficit. Okay, so a lot of people will have selective attention deficits if they're very tired, for example. Okay, or if they're under a lot of stress. Okay, and so I'm sure that you can all think of things like that. Now, sensory inattentiveness. So we have extinction and neglect, and so extinction is when you've got two stimuli. Like, let's say that you've got something on either side of your face, a picture on either side. Okay. You cannot see the one on the right. Okay. But if we just put up one at a time, you can focus on both of them. You can see both of them. But when both of them are there, you can only see one. Okay. So there's extinction of the other one. And that usually, so like, let's say that the left one was extinct, the left one disappeared. That would indicate a lesion of some sort on the right side. Okay. Now, neglect is different. Okay. Neglect means it doesn't matter that there's that second stimulus. Neglect, you're not going to pay any attention to that one on the left side, even if there's nothing on the right side. Okay. And so people who have neglect have often had a stroke that affected one side of their brain. And because of it's because of the stroke on that side of the brain, that damage on that side of the brain. And remember, we're talking about contralateral things here. They'll have difficulty paying attention to everything. Let's say it was on the right side of the brain. They're going to have difficulty paying attention to things on the left side of the brain. So that's neglect. We also have alterations in attention and memory. So amnesia is forgetting things that have happened. Retrograde means you forgot the events leading up to this point. Retrograde amnesia is very common with head injuries, even mild head injuries like concussions. Okay. Anterograde amnesia means that you cannot make new memories. Okay. So the movie 50 First Dates is about anterograde amnesia. And somebody mentioned another one that I can't remember now, that's also an example of anterograde amnesia. We also have executive attention deficits. And the biggest example of those is ADHD or ADD. Okay. So because they're both very similar disorders. Okay. And we know that ADD and ADHD affect what we call our executive functions. Okay. So the executive functions of the brain are things like your memory, your emotions, the higher level thinking that allows you to prioritize things, to control your behavior. All of those things are what we call executive attention, executive functions of the brain. Okay. And so ADHD affects those executive functions and makes the person with it less able to do those things. Okay. So this table here shows you the prefrontal cortex, for example, organization, self-control, your attention. Okay. Those are all affected. The reticular activating system. These are changes in this area cause impulsivity, hyperactivity. Another thing that helps us with our attention. Okay. Basal ganglia, this is not usually affected by ADHD, but sometimes it is. This is responsible for motor control. And then finally, the limbic system is your emotions. So all of these things are going to be affected by ADHD, which is a type of executive attention deficit. So it's an alteration in awareness. Now, image processing can also be a sign of some type of brain lesion. And that's when you look at a cup, for example, and you call it something completely different. You cannot process what you're seeing. Okay, so I look at my Starbucks cup here and I call it a fork. Okay, and I don't know that this is not a fork. And so that's a problem with image processing. And we also have alterations in muscle tone. So with neuromotor function, hypotonia. This picture here, of the toddler who is being picked up here. This is an example of hypotonia. So they can't voluntarily move very well. Okay, so we have very limited movements. We have very weak movements. That's hypotonia. Now, there's several types of hypertonia. Spasticity is a particular type where muscle spasms are increased by movement. And so these patients have exaggerated reflex responses. Here are examples of spasticity. Okay. I'm sorry, this one is the example of spasticity. The person was reaching for something, but they have muscle spasms. Okay. Gegenhalten is a type of rigidity. So these are examples of rigidity here, okay, because where the muscles are just contracted and rigid. Gegenhalten is a rigidity that we detect on passive movement. So for example, if I tried to move someone's arm, if it was bent and I tried to straighten it, Gegenhalten means that they pull back and resist me. If I pull harder, they pull harder. Okay, that's also called paratonia. Dystonia is uncontrollable muscle contractions, and it causes the affected body part to twist involuntarily. So they have really abnormal postures. So this lady here has dystonia. She can't move her neck back into position. Okay, it can affect just one muscle. It can affect a muscle group. It can affect the whole body. Moving on to paresis and paralysis as symptoms. Here we need to distinguish between the upper motor neurons and the lower motor neurons. So remember that your upper motor neurons originate in the cerebral cortex and they go down to the brain stem or spinal cord. But your lower motor neurons begin in the spinal cord and then they go to muscles and glands. Okay. So when we have upper motor neuron syndromes, some examples of these are going to be hemiparesis or hemiplegia, which are basically, are you paralyzed or are you weak? Diplegia, paraplegia, quadriplegia. We might see pyramidal motor syndromes. So a pyramidal motor syndrome where we have dysfunction of these tracts of the spinal cord. Okay. And because remember that we're talking about the motor neurons that go down into the spinal cord. And so we may see hyperreflexia. We may see changes in other reflexes. So the Babinski reflex, for example, where you draw something up the foot. Okay, so you take like a pencil or something and you go up the foot. You're supposed to You're supposed to curl your toes when somebody does that. A positive Babinski is where you flare your toes. Only babies are supposed to do that. Okay. So changes in reflexes like that. Fine motor skills are also going to be affected by pyramidal motor syndromes. And then finally, spinal shock, which we'll talk about when we talk about spinal cord injuries. Okay. Now, lower motor neuron syndrome. Here we're going to see flaccid paralysis. Okay. So instead of a spastic paralysis, where we have a hypertonia, maybe we have some of these. Now we see flaccidity. Okay. We'll see hyporeflexia or maybe complete lack of reflexes. Okay. As opposed to, remember, our upper motor neurons, we saw an increase. We saw hyperreflexia. Fibrillation is something that we'll see with lower motor neuron syndromes, and that's actually where there's a lot of twitching of individual muscle fibers, but the whole muscle doesn't work. It doesn't move, and that's if that motor neuron that was supplying that muscle got destroyed. So then the muscle fibers that it goes through don't have anything to do. Okay. And then finally, what we call our amyotrophies, okay? And so we are going to talk about like ALS, amyotrophic lateral sclerosis. Guillain-Barré is one of these. Polio was one of these. We've got our palsies in here. So we're going to talk about these, but these are damage to the lower motor neurons. Extrapyramidal motor syndromes. So these are syndromes that are outside of the pyramidal, the pyramidal system. Okay, so two examples here. First off, your basal ganglia motor syndromes. This is typical of Parkinson's disease. Okay, where you have an imbalance of dopamine and acetylcholine. A lot of times here we're talking about not enough dopamine in our brains, okay? And that's what we have a problem with Parkinson's disease. So we have hypokinesia, where things move slowly. This is also often caused by meds for schizophrenia. And so we'll talk about them having extrapyramidal side effects when we talk about those meds. Okay, and that is so the extrapyramidal side effects, I'm actually going to talk about those on the next slide, but they include some of our symptoms of Parkinson's. Cerebellar motor syndromes, on the other hand, these are associated with ataxia. Okay, so this is going to be your patient who looks like they're drunk. Okay, they've got slurred speech, they stumble, they fall, they're incoordinated, and this is caused by damage to the cerebellum. Okay, because remember that your cerebellum is what gives you your coordination. Now, it's typically if you've got damage on the, only one side of the cerebellum, then you're only going to have those symptoms on one side. But even if only one side of you is uncoordinated, you're still pretty uncoordinated, okay? That can be caused by alcohol or meds, but it can also be caused by things like strokes, brain tumors. Multiple sclerosis can cause that. All right, so here are some of our movement disorders. So hyperkinesia is an excessive but purposeless movement, okay? So when we talk about hyperkinesia, we've got examples that include things like wandering, okay? If your patient wanders, it's not so we see this with patients with Alzheimer's disease who wander. Chorea, that's an involuntary movement that affects the shoulders and the face a lot of times, okay? A tremor at rest, okay? So a tremor at rest as opposed to an intention tremor. That's, a tremor at rest we will see with some diagnoses, whereas a an intentional tremor is when you reach for something, okay? A postural tremor is when you cannot maintain a movement against gravity, okay, or you'll shake against gravity. So a postural tremor we check by holding your arms out in front of you. Are you able to hold your arms out in front of you? Paroxysmal dyskinesias are abnormal involuntary movements that occur as spasms, okay? Um, Tardive dyskinesia, this is often a side effect of our meds. And the guy in this picture, he's got tardive dyskinesia as a result of antipsychotics. Okay, so here's an example again down here of tardive dyskinesia. And this is involuntary movement of the face, the lips, the tongue, sometimes the trunk and extremities, but really we're really looking at the face there. And when we have our traditional antipsychotics that we used to use a really long time ago, that's when we saw tardive dyskinesia. Tourette's syndrome starts in childhood, and it involves uncontrollable repetitive movements or unwanted sounds. They call them tics. Repeatedly blinking, shrugging your shoulders, blurting out offensive words. These are all movement alterations, and they are uncontrollable and they're involuntary. Now, hypokinesia is another type of movement disorder, and it specifically means that your movements have a decreased size or amplitude or aren't as big as you'd expect them to be. So it's related to akinesia, which means that you have no movement, and bradykinesia, which is slow movement. We see those with damage to the basal ganglia. So again, basal ganglia damage, we're looking a lot at Parkinson's disease. All right, some of our other symptoms now. Data processing deficits. Agnosia is the loss of a sense, okay? So maybe if it's a visual agnosia, then maybe you can't recognize an object or a face or a place. If it's auditory, you can't recognize a voice. If it's tactile, that means you touch something and you can't tell what it is, okay? That's agnosia, where you lose that sense. It usually involves just one of them, as opposed to like multiple senses, okay? And you can still, you use your other senses to interact with the world. Now, if you are deaf, it's not really called an auditory agnosia, because if you're deaf, you're not hearing it. This is a processing deficit, okay? If you have visual agnosia, you're not blind. You just can't identify things, okay? Dysphagia. We all know what dysphagia is. It's the inability to talk or the inability to understand spoken language. So expressive aphasia means you can't speak, make yourself understood. Receptive is hearing and understanding. It can be either dys, meaning damaged, meaning a deficit, or it can be complete lack of, so aphasia. Transcortical aphasia is a type of aphasia or dysphagia that is damage to the specific areas of the brain. So certain specific areas. And they have poor comprehension of what they hear, but they can repeat it. And they can talk relatively fluently. Okay, so it's just specific areas that are damaged there with transcortical dysphagia or aphasia. Now here, when I'm talking about dystonias, here are the postures that I was talking about, okay? So decorticate and decerebrate, and I've got a couple of slides after this that have pictures as well on how you remember them, okay? So decerebrate is worse, and that's what's actually shown in B. It's indicative of severe brain damage. But the decorticate posturing is still very severe. Decerebrate is even worse. And decerebrate, you've got a lesion lower in the brainstem than with decorticate. Okay. If you've got a combination, then you've got a different level of brain injury on the two sides. So how do you remember them? So decorticate, here you've got problems with the cerebral hemisphere. Your arms are like C's. Decerebrate here, arms are like E's. And this is the midbrain, the pons, your brain stem there, okay? Here's another abnormal posturing picture. This one also shows flaccidity. So remember that flaccidity is another symptom that we will see. We often see flaccidity with strokes. Okay, the side that was affected is often flaccid. Gait disorders, and we're going to talk about. We've just got a couple more things to go through here. Gait disorders are also something that can show some kind of neurologic involvement. So a spastic gait, your spastic gait is shown here, and this is caused by muscles that are more contracted on one side of the body than the other. We will see this with some of our palsies. For example, cerebral palsy has a spastic gait. The scissors gait here has to do with your legs actually crossing in front of them as they walk. So their legs will cross in front of them. The propulsive gait here is actually the basal ganglion gait that I have over here. So that's that kind of front leaning, stooped over posture that we see with people with Parkinson's. Okay. And then the cerebellar gait is when you are very unstable, when you're very uncoordinated. Remember, we talked about how your cerebellum is what makes you coordinated, right? So a cerebellar gait is you look like you're drunk, basically. And then the senile gait is actually that unbalanced posture that really old people get. They walk really slowly. They're bent over. It actually doesn't have anything to do with dementia, but as you get older, they have that really bad body posture, and it causes low back pain, neck pain, chronic back pain, and they will hurt themselves much more if they fall, and that causes the body to change position. So, for example, the senile gait causes kyphosis in the spine, where the shoulders are up above the head, basically. All right, and finally, disorders of expression. Here we have hypermimesis and hypomimesis. So hypermimesis is characterized by pathologic laughter or crying, like the Joker, and hypomimesis is the loss of that emotional language and facial expressions. And then dyspraxia also has to do with expression, because we express ourselves with more than just our face, right? And so dyspraxia is the partial loss of the ability to perform purposeful movements and gestures with accuracy. Apraxia means they completely lose it. And so it can affect your fine motor skills. It can also affect your gross motor skills. All right, that's the end of this video. And in other videos, we're going to talk specifically about the different disease processes that can cause all of these disorders.